I'll go to generic, go to area trace. Then I'll go to two-chamber view. Then I go to length. So I'll take a distance. I'll look at whether this distance is smaller or this distance is smaller. So I look like as if this distance is.
गिरेगा तो नहीं सर, गिरेगी तो नहीं? नहीं, 10 का नोट होता दिया, बोले भैया पैक जल्दी
Tell me
करा
what
दिया।
to do with this person.
सोई में हो गया काम। हाँ, आपने कहा सोची। आप समझदार हो, आपको क्या बताना है।
So 0.85 into area 1 and 0.8 into area 2 divided by 7.4 centimeters. That will be your absolute LA volumes.
Okay.
नहीं, एक बंदा आ जाए वो 150
Divide by
में
body surface
खाना खा के
area.
चला जाए।
That's become your
1.7.
correct.
Sir, why 0.8?
0.8 is a constant. It's not a abnormal. It's a constant out there. Somebody created this formula of 0.85. Dr. Akash Tamrakar, either you silent your mic or you get out of this class. Ravi Gantur, get out of this class completely. And if anybody will open your mic without asking questions, I'm asking the IT people, remove them immediately. And Dr. Akash, I'm removing you completely round from here. You don't have any sense. Come out of this class. Get yourself disconnected. I don't know whether these people are in classes or not. Some people, they do not want to read at all. And they all want to disturb the classes. That's all they are planning to do out here. Okay, Vandana. In that case, what we look forward is, we look forward for the next now part of this presentation. And what do we look for this presentation is, we go to this guidelines of 2016. So what do we look? We look for these guidelines of 2016. If my LA pressures belongs to this category, then it's increased, or we say normal grade 2 diastolic dysfunction and increased LA volume index. But if it's a reduced ejection fractions, in that case, we say grade 1. If everything is normal for reduced ejection fraction, we always call them as grade 1 diastolic dysfunction with normal LA pressures. If we have this formula, we utilize these three surrogate markers If two are positive, we say grade 2 diastolic dysfunction with raised LA pressure. And then look in this, the LA volume index is also 34 cc again. And if A ratio
Yes.
is more than 2, we already say grade 3 diastolic dysfunction with raised LA pressures. So that is indirect marker for diastolic, is indirect marker for LA pressures.
Yes, sir.
Clear?
But we calculate the volume, sir, but how to calculate pressure?
That's what I'm saying. By what do you mean by volumes? Volume is means amount of blood which is present in LA.
Yes, sir. Yes.
So go back to the slide, previous slide. This is impaired filling pressure, impaired filling patterns. Left atrial
Yes,
pressures
sir.
are elevated. So if we calculate this grade 2 diastolic dysfunction, we say elevated LA pressures. Here grade 1,
Okay.
normal or low. Grade 2, grade 3 is elevated LA pressures. And if you want to
Okay.
convert them into numbers, that's what could be another factor you must be asking me. This is how
Yes,
we
yes.
convert them to numbers. Grade 2,
Yes, sir.
grade 2 is
15 to
15 to
20.
20 and grade 3 is more than 20.
Yes, sir.
So it's an indirect measurement. If you really want to calculate pressures, then you have to put a Swan gauge catheter inside.
Okay. Okay, sir. Thank you, sir.
Dr. Ravi Bala Majan.
गुड इवनिंग सर।
Good evening.
सर एलए प्रेशर तो हम पीआर जेट वेलोसिटी से भी कर सकते हैं ना कैलकुलेट?
वो आरवी सिस्टोलिक प्रेशर है। पीआर जेट वेलोसिटी के प्रेशर्स किस में जाएंगे? आरवी में, आरए में?
आरवी में सर।
देन
सर एंड डायस्टोलिक प्रेशर जो हम मेजर करते हैं वो मीन एलए प्रेशर ही बोलते हैं ना?
लेफ्ट वेंट्रिकुलर एंड डायस्टोलिक प्रेशर, oblique LA mean pressure,
यस
LV
सर।
filling pressure, at your level, all of them are same.
यस सर। सर माय क्वेश्चन इज wall motion abnormality in left bundle branch block.
What is your question?
सर वो जो सेप्टम का मूवमेंट है वो समझ में नहीं आता सर एलबीबी में।
Okay. So I'll stop sharing this slide over here. I cannot shorten this down. I'm going to do that. I'm closing it down one by one. Archive. Shorten this down. Give me a second. I'm trying to bring that slides back for you.
यस सर।
Can you see my slides? All right. This is for Dr. Ravi Bala Mahajan.
यस सर।
Septum. This is inferior wall. This is not posterior. Thou is a three-chamber view, but this is a posterior wall, inferior wall. Why is that?
पैपिलरी मसल सर।
Correct. Good question answer. If you happen to see a papillary muscle, then it's inferior wall. If you don't see a papillary muscle, then it's a posterior wall.
यस सर।
Now look at this septum. is not jerky septum. But
Sir, not much clear.
Is jerky, but thickening is maintained in the septum.
Thickening is normal. Yes, sir.
Can you appreciate the thickening?
Yes, sir.
So this is a case of LBB with normal LV systolic function. That's one point. You see a maintained endocardial thickness and thickening while contraction. Second is go to two-chamber view. Look, there is no abnormality in two-chamber view now. It is very well thickening now.
Yes, sir.
In LBB and RBB, which part of the cardiac cavity would be affected?
Sir, LBB में तो left ventricle, RBB में right ventricle.
No. What do you mean by LBB and RBB? Left bundle branch block.
Yes, sir. Bundle of his sir AV node से जो left वाला है,
बिल्कुल
वहाँ पे blockage है.
तब ब्लॉकेज है तो क्या होगा? पहले राइट वेंट्रिकल एक्साइट होगा.
Yes,
और
sir. फिर left.
राइट बंडल एक्साइट होगा and then will spread to left side.
Yes, sir.
Left bundle branch block में this is what is going to happen. If it's a RBB, then left will get excited and then will excite the right one.
Yes, sir.
Correct. So it's a factor for LV only. But it will be affecting septum, not the anterior wall or the inferior wall. Look, if it's LBB or is affecting along with anterior wall MI, anterior wall is consistent of this anterior wall.
Yes, sir.
And there is no involvement of anterior wall.
Yes,
So
sir.
you can find LBB with anterior wall MI or without anterior wall MI. The question answer would be if it's anterior wall MI along with LBB, in that case, your septum thickening would not be there. On top of that, in anterior wall will be affected in anterior wall MI. It will not be affected in anterior wall.
Yes, sir.
Clear?
Yes, sir.
And second thing is, if you really want to be very, very comfortable, look what exactly happens. Look, this is normal interventricular septum, anterior interventricular septum contraction. With diastole, they are going back and it's showing an expansion during diastole.
Yes, sir.
With systole, it's coming into a systolic position.
Yes,
And
sir.
you happen to see this two beaking kind of a pattern. Look, this is systole and then goes diastole, come inside and then goes diastole again to complete the diastole. So you see one extra beak during the LBB patterns.
Yes, sir.
So M mode, parasternal short axis at papillary muscle will give you a fair good idea.
Yes, sir.
And this is, which is very important. This is available in all books. Look, this is the normal. This is LBB kind of a pattern. This is R volume overload, post-surgery, constrictive pericarditis, and left ventricular volume overload. So these
Yes,
are
sir.
non-ischemic wall thickening abnormalities.
Yes, sir.
Clear?
Yes, sir.
All right. Let's
Okay.
move on to Dr. Arif now.
Good evening, sir.
Good evening.
Sir, is it possible that just by remembering the shape of E and A and side by side comparing it with E prime, we grade it grade 1, 2, 3?
Say it again a little louder.
Sir, is it possible that just by remembering the shape of E and A and side by side comparing it with the E prime, we can grade it diastolic dysfunction as grade 1, 2, or 3?
No, certainly not. Are we talking of 2024 or are we talking of 2004?
Because sir, the shape matches grade 2, and if there is a sorting of E prime, then we can.
I'll show you ample examples where E ratio is less than 1 in reduced ejection fraction and my grading of diastolic dysfunction is grade 2 or grade 3.
Yes.
every management of heart failure patient is consists of what? Just tell me one single answer. Dr. Arif, where are you located?
Yes, sir. Yes, sir. Ranchi.
Right. Have you ever seen heart failure clinics?
Clinic.
Proper
No,
heart
sir.
failure clinic.
No, sir.
If you go to heart failure clinic, what they are looking for? They are looking for LV function, LA
Yes, sir.
pressures, RV systolic pressure, RA pressure, and IVC. 5 things they are looking at every time.
Okay, sir.
Now, next answer is, you must have seen in a practice somebody who has got a 25% ejection fraction roaming around comfortably.
Hmm.
Correct? On the other
Yes,
hand,
sir.
25% patient is lying in the bed. Ejection fraction is same. Why so? Did
No,
you
don't
ever
know, sir.
think of this?
LA pressure.
3 matters, 4 matters. LA pressures, RV pressure, RA pressure, IVC size, and
IVC.
collapsibility with RV function. A guy who's moving around he has got 25 ejection fraction, normal LA pressure, normal RV systolic function and pressures, normal RA size, normal IVC. The person who's bedridden has got raised LA pressures. He's almost lying in the bed in a sitting positions. He is swollen, his legs are swollen. He has got a dilated IVC. He has got a poor RV systolic functions. And what do we do in heart failure clinics? If I happen to see a large IVC, so what do? I'll jack up my dose of diuretics so that I reduce my IVC size to normal, less than 21 millimeter in size, which collapses more than 50%. So I consider my RA pressure to be normal.
Yes, sir.
On the other hand, if my LA pressures are elevated, I'll reduce the preload. What I'll do? I use ACE inhibitor,
Yes.
ARBs.
Yes, sir.
If my blood pressure is high, then what do? I correct my blood pressure. So by changing these parameters, we are able to control these people as far as their symptomatology is concerned. Very simple answer is, a person of hypertension, when he goes to LVF, how does it present to casualty or emergency ward? Severe breathlessness, right? I'm
Yes,
sure
sir.
you must have done it before.
Yes, sir. Yes, sir. Yes. Seen
So what
also
do you
this
give
case.
him?
We
You give
reduce
him
the pressure, sir,
lastics
and
along
diuretics.
with oxygen levels. So what a positive pressure when the BiPAP mask is doing is pushing fluid outside the lungs. And lastics is reducing the preloads. BP is very high, we give IV TNG, nitroglycerins. So afterload is reduced, preload is reduced. And the patient who's tachycardic, 120, 130 heart rate, oxygen level is low, BP is low, and gradually starts coming up, reducing his heart rate, better oxygen saturation, and breathing levels by 30 to 40, his breath comes down to almost 18 to 20. I hope I am able to clear your doubt.
Yes, sir.
So
So we can,
do it
sir.
properly.
So
Don't just a
yes,
minute.
sir.
Do it properly. Just don't look at it and believe my words. When you start doing it properly, lot many things will change in your practice. Somebody was asking something.
Thank you, sir.
Right here. Dr. Mahananda Matre. Unmute yourself and go ahead and
Yes,
ask
sir.
the question.
Good evening, sir.
Good evening.
Sir, difference in diastolic dysfunction in preserved ejection fraction grade 2 and grade 2 diastolic dysfunction with reduced ejection fraction. They had mentioned E by E prime ratio in normal ejection fraction people 10 to 14. And here all the 3 criteria are there in a reduced ejection fraction that E by E prime should be more than 14. So
That is grade
normally,
3 diastolic dysfunction. If you
okay.
remember a few minutes back, what I said to you was,
Yes.
I said That presentation, I have to open it up. Just give me a second.
With reduced ejection fraction, it's
Wait
clear,
a
sir.
minute. Just give me a second. Give me a second.
Yes.
This computer is so fully loaded. So I have to go along with the computer to answer your questions, you know. If I press it too fast on this computer, it start hanging on, despite the best I have as on today. Look, it's taking time to open up his slides. Give me a second. It will open up all the slides in one go, and then, yeah, it's gone. Now look at this slide.
Yes, sir.
Diastolic dysfunction in normal subject population.
Yes.
What does it say? EA ratio. First look at EA ratio. 0.82 less than 2.
Yes.
Average E2 prime 10 to 14. TR jet velocity more than 2.8. And LA volume index increased.
Yes.
So here is a cutoff. And if I go to reduce ejection fraction, then 0.8 to 2. Look, this is 0.8 to 2.
Same.
More than 2. If it's more than 2, state will go to grade 3 diastolic
Grade three.
dysfunction with raised LA pressure. If it's between 0.8 to 2, we look at these three parameters. Same parameter, average E2 prime, TR jet velocity, LA index. So average E2 prime, TR jet velocity, LA volume index. If
Sir,
two are
average
positive,
E to E prime, they had mentioned different, na? 10 to 14, they had mentioned with the normal ejection fraction. That's what I was
10
here.
to 14 is over here.
Hmm.
So here is more than 14. This is
Yes.
reduced ejection fraction. If it's more than 14, more than 2.8, more than 34, then we classify them as grade 2 diastolic dysfunction.
Yes, sir.
That is reduced ejection fraction. So put this chart in your lab. Reduce means, what is ejection fraction reduce you're talking about? Less than 50.
Less than 52 in
50.
males and less than 54 in females.
Correct. Okay.
Yes, sir. So for normal ejection fraction people, we have to have a E by A between 0.8 to 2. Then E by E prime between 10 to 14. And TR velocity has to be more than 2.8 to grade it as a grade 2.
Correct.
So all the three criteria has to be fulfilled.
Not 3. 1, 2, 3, 4.
4. LA volume also.
Correct. Because LA volume is a very important criteria.
Yes. Okay. Thank you, sir.
And even reduce also LA volume index is also very important criteria. Both index
Yes.
LA volumes. Index means whatever the LA volume you calculate, divide by body surface area.
Yes, sir.
Clear?
Yes, sir. Thank you.
All right. So let's move on
Sir,
to
and
money.
one more
Okay.
doubt, sir.
Okay.
While measuring those TDI and E prime, they mentioned reduce the gain, reduce the filter. Gain knob is there. How to reduce the filter to get the better images?
Okay. So let me just close down this image. Can you see my machine now?
Yes, sir.
Okay. What do we mean by reducing the gain and reducing the filter, right?
Yes, sir.
And this is what the image is. Now I'm increasing the gains of this image.
Okay.
So what exactly happening? I'll be
Blurring of image.
overestimating my TDI velocities. And now I'll reduce to optimal gains. Now this is optimal gains. I have to measure my TDI velocity over here.
Yes, sir.
Second, this image is not correct. Once I'm doing a tissue Doppler imaging, let me just look at some other image. Remember that image? In your mind, I'll tell you what is the difference. You tell me what is the difference in that image and this image. Okay. That was one TDI velocity. This is another TDI velocity. What is the difference in this image, the upper one, and what was the difference in previous image?
This is more clear.
Pardon?
In this image, we'll be able to measure it properly. When the gain was
Correct.
increased, it was blurred.
No. Important thing is, look at the sector which I've reduced over here.
Okay.
By reducing the sector, I'm getting a higher frame rate, and this Doppler spectrum pattern has become much better.
Okay.
Previous, the sector was covering the whole image of a 2 dimensions. So we reduce this sector, and then we can look at this tissue Doppler imaging velocities.
Okay. Got it.
Let me just see if I can put in the sector. Tissue Doppler. If I can put it, let me just TDI. No, this is not possible to put a TDI. You put a TDI over here. So, and reduce the sector scan in 4-chamber view. This is I've shown you for just, I can show you in 4-chamber view. Okay. Let me try if I can put this tissue Doppler in this. No, I cannot put a tissue Doppler. Only thing is I can put a tissue Doppler image across whole of this sector, or I can put just on the septum or the lateral. So get a better image quality. All right.
Yes, sir.
Sir, we need to reduce this 2D sector also, or only this TDI
Only
sector?
the color sector.
Thank you, sir.
Look, I have reduced only this TDI sector, not the 2D image, because otherwise, how do I know where I'm putting the sample volume? That was septum, which I showed you earlier. This is lateral one. Clear?
Yes, sir. Sir, and then they say sample volume size. How can they reduce the sample volume size? 2 millimeter, 3 millimeter, 5 millimeter.
Machine. Which machine do you use?
G machine.
G machine has got a sample volume right in front of you on the screen. Look at the sample volume. I'll just show you on the screen again. Let me just take this image. This is not an exactly a place where to show you, but I can show you the sample volume is right over here in a machine, in the front of your machine.
Okay.
It will show you sample volume. As soon as you open your sample pulse wave sample volume, it will ask you in front of machine sample volume. If you can't get it, ask your senior. If you can't get it, call on a WhatsApp. I'll show you then and there.
Okay, sir. Okay, tomorrow I'll see it. Yes, sir.
Dr. Mani Chandra.
Good evening, sir.
Good evening.
So when we talk about the RV dysfunction, sir, can you teach us in details regarding this acceleration time less than 100 millisecond and the Doppler spectral pattern showing some mid-systolic notching, late notching in the RV spectrum?
May I know your question again, Dr. Mani Chandra?
So when we talk about RV dysfunction, sir.
RV dysfunction. Okay.
Yeah, RV dysfunction, sir. the Doppler spectral pattern, are we out?
Diastolic dysfunction or systolic dysfunction?
Are we systolic dysfunction, sir?
RV systolic function, what you're looking forward is?
Sir, RVOT, when we do about the Doppler spectral pattern showing some left notching and the mid systolic notching.
Why did you read it? Because RV systolic dysfunction is, we look at RV free wall TDI, we look for TAPSE, we look at RV fraction area change. Possibly what you are talking about is RV systolic pressures.
Yes, sir.
Is that correct?
Okay, sir.
So mid-systolic notching, if you're talking about mid-systolic notching in RV pressures.
Yes.
So let me show you how do you look for RV systolic pressure in mid-systolic notching. Give me a second. This is what possibly you're talking about.
Yes, sir. Yes.
You are not talking about RV systolic function. You are talking of a TRZ Doppler velocity pattern where, as we see it, is a tongue-shaped pattern. As the pressure increases, acceleration time becomes shorter and shorter. And when you have a severely elevated pulmonary artery pressure, despite short acceleration time, you find a mid-systolic notch. What is the importance of this? In cases of ARVC, arrhythmogenic right ventricular dysplasia, when the RV-RA pressure, they become equalized. And when they become equalized, what happens? The TRZ velocity will be only 25. But the pattern would not be up like tongue-shaped or parabolic. It will be a sharp acceleration time and slow deceleration time with a velocity of only 2.5 to 3 meters per second. In fact, one of the characteristic feature of ARVC is when we have a velocity of less than 2.7 meters per second. Despite the fact we have an equalization, RV systolic pressures are very high. So we have seen this kind of pattern, and we may see this kind of a pattern in this mid-systolic notch. And when we see this or this kind of a pattern, we always understand that pulmonary artery pressures are very, very high.
Okay, sir.
Clear?
Yes, sir.
This is RV systolic pressure, what you were looking at, mid-systolic notch.
Okay.
All right, Dr. Mani Chandra.
All right, sir.
Janvi.
Namaskar, sir.
Good evening. Go ahead.
Is there we have to adjust the volume of sample volume also? Is there any lows for small volume, sample volume? Is there the concept of like that? It is somewhere written. You have to add the small sample volume when you are putting PW.
Sample volume size is almost 3 to 4 millimeters, not millimeters.
That will be fixed in machine only, na sir? We
You
need
can
not to
fix it
adjust.
in a machine. You don't have to change the sample volume again and again. Just use 2 to 4 millimeter of sample volume.
Okay.
Because what exactly you're looking forward, you're looking for pulse wave Doppler spectrum pattern. Pulse wave means site specific.
Yes.
And if it's a site specific, you need not have a large sample volume. It's 2 to 3 millimeter, 2 to 4 millimeters. It all depends which kind of machine you're using and what is the minimum size of the sample volume in your machines.
Okay. Need not to change as per condition. Okay.
We never change. We keep the sample volume static.
Okay. Thank you.
Anybody else? Dr. Ripan,
Good evening, sir.
good evening.
How to differentiate constrictive pericarditis versus restrictive
Okay.
in relation to EA ratio? Like,
I'll just show you. Just give me a second. I have the topic already opened with me. I was just expecting this question, so I was ready with your answers. This is in the books. What is talk of prominent wide descents, paradoxical pulse, pericardial knob, equal right-left filling pressures, filling pressure more than 25 millimeters of mercury, pulmonary artery, systolic pressure, square root sign, respiratory variations, ventricular thickness, atrial size, septal bounce, tissue Doppler imaging velocity, pericardial thickness. If you ask me how to differentiate constrictive versus restrictive pericarditis, I have got very few important things which you have to have in mind. One is E to E prime ratio. What would be the E to E prime ratio in restrictive cardiomyopathy? Dr. Ripan,
yes, sir.
what will be the E to E prime ratio in restrictive cardiomyopathy?
It will be more than 8.
It's increase. If you
It
look
will
at
be
E to E
increased more
prime
than 8.
average is 10 to 14 or more than 14.
Yeah, more than 8.
In constriction, it will be reverse. Correct? Then
Yes, sir.
second important answer is annulus reversus. What is annulus reversus?
No idea, sir.
Normal septal annulus is more than lateral annulus. Sorry, lateral annulus is more than septal annulus. In constriction, the septal annulus would be smaller, bigger than lateral annulus. Remember, in normal condition, septal annulus is smaller than lateral annulus. In constriction, septal annulus would be bigger than lateral annulus. Why? Constriction means around the heart there is a constriction, thick shell of calcium, 99%. So septum can still relax, but in constriction there is a stoppage for a lateral annulus because it cannot relax properly. And third very important side is hepatic venous flow reversal. What is hepatic venous flow reversal? During hepatic venous flow reversal means when a patient starts breathing out, the interventricular septum to accommodate the LV moves towards the right side. And in that, it reverses the flow from hepatic vein, IVC to hepatic veins. So these three important things differentiate to a large extent. Fourth, you can have a calcium shell around the heart. So what do we need? We need a CT scan, cardiac CT scan, not coronary, cardiac CT scan. So remember these four things, which will make your life very easily, because this is non-changeable, this is non-changeable, this is certainly not changeable, and calcium may be there or may not be there because number of times we are seeing people presenting with post-surgery restriction or post-surgery constrictive pericarditis. Let me just show you a case. It's my armamentarium right now. You can see my screen, right?
Yes, sir.
This is constrictive pericarditis. It has got all the beautiful features of constrictive pericarditis. All right, it's not there. Anyway, let me stop and shift over to my computer to other side. All right. We finally got him. Can you see the slides now?
Yes, sir.
Okay. I'll start with the history. 71-year-old male, 2001 he took ATT for 6 months. 2018 rheumatoid arthritis on regular treatment. 2021 diagnosed as portal hypertension, normal endoscopy. Remained well this time in June 2023. Since 1 month, he is having fever with poor appetite. So this is all in front of you right now. Then this is investigations of 3rd July 21 and 31st May 23. Hemoglobin has dropped, ESR is increased, SGOPT, rest everything is normal, nothing significant. Then look at this CCP antibodies in CRP, along with rheumatoid effects, significantly increased at this time right over here. This is his prominent bronchovelocity marking, pectio opacity seen in right lung, query infective etiology. Both diaphragms are normal, right CP angle is obliterated, cardiac size normal. This is his ECG. And now let's look at an echo. So this patient has got a large compression on this side. And look at the Doppler flow pattern, tall E, small a. Now look at this E prime septal. E prime septal is only 9. E prime lateral is 11. Correct? Then EA ratio, mitral Doppler spectral flow. And this is what a tricuspid flow pattern is in this patient is. And if you look carefully, this interventricular septum and this is bulging. And finally, what we get is, just show you. No, it's not there. It shows a hepatic venous reversal flow. It did not show in this picture. Let me find out some other case.
First view after the expiration, no, sir? After expiratory phase, you are
Beautiful. It's
that you are explaining.
Scratches.
it's
That was
such a
question also
beautiful-
in our.
It's such a beautiful expression which is seen in hepatic flow venous reversal that is not seen in any other condition. I'll go to pericardium. It is there in pericardium. Just give me a second. You know, is not a easy things at your level. We don't expect like you people to diagnose constrictive or restrictive. But if it's somebody has asked this question, I'll explain you. Now look at this flow pattern. This is inspiratory. This is expiratory. Correct? And as soon as we have a constrictive pericarditis, this flow pattern till now it's going down. And as soon as the expiration starts, this goes up. So if you ask me, where do I put my emphasis to a large extent? I always put my emphasis on large extent only in couple of things. Forget about everything. Look at the annulus reversals. Look at the reversal of flow in first beat of expiration. Look at the thick shell of a calcium, may not be there. And finally, look for a CT scan. And last is E to E prime ratio, which is large in restrictive and small in constrictive pericarditis. In fact, whenever I see a constrictive pericarditis, if I see a E to E prime ratio of 4 or 5, you know, my ears start ringing. Are we looking at constrictive pericarditis? Because if normal person also, E to E prime ratio has to be between 8 to 10 or about 8. That's how we look for these kind of things. I could not, I was trying to show you a ventricular interdependence. I hope there's a slide on ventricular interdependence. And that is the reason, look, this is a patient of constrictive pericarditis. Lateral E prime is only 4. And if you look at this septal E prime, this is 9. So lateral restriction is there to open up it completely. So this is how we look at, and this is dependent on the phenomena of ventricular interdependence. And these things really make a difference in our clinical life. I hope I should show you one ventricular interdependence. I don't think like I can locate it right now.
And can you show sir cardiac tamponade diagnosis?
Cardiac tamponade is more or less the same. In cardiac tamponade, respiratory variations are there more than 25%, both LV and RV. IVC plethoric. And on top of that, you have a systolic compression of RA and diastolic compression of RV. Because pericardial tamponade is intrapericardial pressures are more than intracavitary pressures. RV pressure and RA pressure. RV pressure is only 25. RA pressures are only 5. So RA is the first structure to get compressed by pericardial tamponade. So denting of pericardium tamponade is RA compression during systole and RV compression during diastole. That's what is pericardial tamponade, along with more than 25% of respiratory variations. But we do not see any variation in the septal and lateral annulus.
But are you
We
having
do not see
that?
any reversal flow in hepatic veins.
Yeah. But still, video can you show some? Are you having that recording? Tamponade.
Just a minute. I was looking for a pericardial tamponade, but I've got a reversal of flow in hepatic veins.
Okay.
Just give me a second, I'll show you that. That pericardial tamponade I can locate, but the problem with pericardial tamponade is like those slides have to be made by me. But I'll try to do that as fast. Give me a second. Just let me show you first the. Now, this is a process. Now, look very carefully what exactly is happening in this patient. This is RA. This is hepatic IVC. This is hepatic vein. Normally, blood should flow all the time during systole and diastole from hepatic vein to IVC. Correct?
Yes.
So, color would be blue all the times. Here, the color is red intermittently. So, let me hold when the color is red. Now, look, this is at the end of a systole, and this is during diastole, the blood flow is happening, reversal of flow.
Yes.
Now, look at carefully. And if I put a Doppler spectrum pattern, this is what exactly is happening. The flow which appears to be there in diastole, the whole flow is seen during systolic reversal. This is all systolic reversal. And in which condition do we expect a systolic reversal?
Severe tear.
In
Severe tear.
Severe tear.
severe tear. Perfect. And if it's a pericardial constriction, This will change, will not be seen in every systole.
Yes,
Will
only
be only
expiratory.
seen
Post.
during first beat during expiration.
Yes.
Now you see a constant all phenomena, all systole showing whether our interval has varied, but is only showing the system. So this patient has got a very severe tricuspid regurgitation. Look at the RSIs. Look at the
Yes.
IVC dilated. Look at this
Yes.
hepatic veins.
Yes.
And this was a patient who had come to get his lower limb venous Doppler done for swelling lower limbs. He had bilateral lower limb swelling, where the cause was not in the lower limbs. All venous structures showed systolic reversal in venous Doppler flow patterns. The venous Doppler flow pattern was pulsatile.
Yes, sir.
So that is how these, you must have read pulsatile lever. I'm
PR.
talking of pulsatile venous Doppler spectrum.
Venus.
Sir, 1 second, sir. Can you show the previous Doppler spectrum which you showed that
Ask me
systolic
the
reversal?
question. Yeah.
So the previous Doppler spectral pattern. Yes, sir. Sir, here the spectral pattern above the baseline is the systole that you mean, right, sir?
Correct. How do you
And
say above systole is? Look at the QRS complex from here to end of T wave. The blood is flowing from IVC to hepatic veins. In diastole, there's still a blood flow with hepatic veins to IVC. So this is diastole. 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 This is diastole.
okay.
Correct?
No, yes, sir. Normally both systolic and diastolic should be below the baseline of the spectrum.
Hepatic venous flow pattern is something like pulmonic venous flow pattern. In pulmonic veins, whenever you have a severe MR, what happens to systolic flow pattern? Either it gets truncated or reversal of flow happens.
Okay, sir. Okay, sir. Understand, sir.
Got it?
Got it, sir. Thank you so much, sir.
Thank you, sir. Thank you.
My another
Janvi, go
question
ahead.
was, sir, I
Yeah, go ahead.
want RV function in relation with this pulmonary RV infarct and pulmonary embolisms. How to assess or what are the
RV
pictures
function is
and to compare?
always by TAPSE RV free wall TDI. Just
Okay.
give me a minute.
Sir, having said that video showing RV infarct or pulmonary embolism and RV function.
Let me just try to look at it. Give me a second.
Okay, sir. Thank you.
Number slide. Okay. So this is how we look for RV functions. We look for TAPSE, RV free wall TDI, two-dimension stain. At your level, look at TAPSE and RV free wall. How do you look for TAPSE? We go to four-chamber view, put a cursor across this tricuspid annulus, and let how much it is moving from this point to this point. Anything less than 17.5 is considered as abnormal. So let's move this thing to 17.5. Is considered as systolic dysfunction. Second
And that
value
is
of looking at is RV free wall TDI. So what we do in RV free wall TDI, we put a sample volume across RV free wall, that is RV free wall over here. We have put a sample volume on RV free wall. You can do in four-chamber view, you can do in two-chamber. Parasternal short axis view at aorta. So we have done in parasternal short axis view at aorta, and this is whole of the RV free wall. And this is what the value we should measure it. If this value, systolic contraction, is less than 9.5 centimeter per second, it is known as RV systolic dysfunction. Correct? Now look at this patient. This is inspiratory wave, this is expiratory wave. And this expiratory wave is less than almost 8 centimeter. This is a case of pulmonary embolism. Dilated RV outlet, RV is over here, outflow is over here. And look at the thrombus sitting over here. Look at very carefully. This is a thrombus and RV function is poor. Right? And third important thing to differentiate RV's function is when we have apical sparing with reduced mid and basal RV free wall. What was the concept when we read in McConnell sign? You remember that McConnell sign?
yes, sir.
In pulmonic embolism, we had a McConnell sign where we had apex was spared, mid and basal segments were reduced. And here the apex is spared in the previous picture and mid and basal septums are spared. So here is -7, rest is 12 and 16 or 15. So this is how we look at these patients who have got RV systolic dysfunction. And third, in pulmonary embolism, what will happen to IVC? It will be huge, plethoric IVC. Only one condition where IVC could not be plethoric. Tell me what is the condition where IVC will not be plethoric? Over judicious use of diuretics, patient presenting with CHF. Because these patients will present with CHF.
Yes, sir.
So what anybody walks into casualty, the first thing what we give is Lasix. Without knowing the fact this patient is a pulmonary embolism. And if it's a pulmonic embolism, we have to load fluid, or RV infarction, we have to load fluid rather than giving Lasix.
Yes.
Or pericardial tamponade, we have to give fluids rather than Lasix.
Yes.
Clear?
Yes. Thank you, sir.
All right, John. Arif, go back again.
So sometimes while measuring the LVEF in M mode, septal thickness appear after the posterior wall thickness. Is it because LBB?
Say it again.
So sometimes while measuring the LVEF in M mode, septal thickness appear after the posterior wall thickness. Is it because of LBB?
Septum thickness
appears after the posterior wall thickness.
Okay. Yeah, that could be a possible factor. Normally, there is a septal posterior wall delay, less than 130 milliseconds. Look, septum and posterior wall, they'll not contact at the same time. If reverses happen, that could be possible of LVB or poor LV systolic function.
So, sir, in that case, how to measure the sir LV ID systole, sir? We assume the thickness of the septum at the level of the posterior wall.
Okay, just give me a second. You want to measure the IVs in this size of the LV, right?
Yes, sir. Yes, sir. During systole.
Okay. Let me tell you what we do in 2024 is we never ever measure by M mode as far as LV size is concerned.
Yes. Simpson's method.
No, Simpson method is gone, man. Simpson's method is gone to Burma, Myanmar. So we never do this measurement. And how do we really measure the LV today in 2024 is look, this is end diastole, beginning of systole. Can you see this red dot over here?
Yes, sir.
So if I have to measure my LV during diastole, so I'm going to measure just basal posterior wall and basal anterior septum. That's first of all. Same thing, I'll go to end systole. So this is about 53 divided by body surface area. I'll come to all three of points. Now I'm going to get rid of these measurements. So I'll move my cursor to systole, end of a systole. Now I can't see a posterior wall. I'm going to increase my gains. To look at my posterior wall is over here. And then I go to measurements at the same level where I measured my. So this is 39 divided by body surface area. That will be a LV size during systole. Now your question is, what exactly happens during this time? So let me just look at this M mode, no, LV mode. So I have to move this away the window. Now, normally what exactly happens, the septum and lateral wall, there is a significant delay. Your question was, let me go to that significant values, put my M mode in that. Gain increase. I'm trying to show you the gains, you know. Now
Yes,
look at this septum. This septum is contracting over here and this posterior wall is contracting over here. So let me measure with a timer. So if this is the peak of this septum and this is the peak of the posterior wall, is almost 120 milliseconds of a delay. Correct?
yes, sir.
Your question is, if it's LBB, what happens? Correct? So if it's a LBB, if I go to measurements, dimensions, suppose this is a LBB means the segment it comes in, then goes out. So what we utilize in the segments is so we'll start from here diastole and look at this long line, which is green color line going along with it. So this will help you in understanding. Then next is dimensions. So here is my posterior wall, and then this is posterior wall further, And this is over here my systole, and here is my posterior. So what we use this line, long length line, to say the measurements. But whether it's a M mode or 2D, the preference of choice would be 2D rather than M mode. So I'll use always this spectrum pattern. If an LBB is there, let it come to systole. I'll measure this systolic and diastolic dimensions.
So in M mode, we assume the thickness of IVS at the level of
IVS at the
posterior
level
wall.
of when it's contracting the maximum.
At the level of posterior walls, maximum
Posterior
thickness.
wall, when it's the maximum, that line, extra line will help you out in doing that work. Suppose this line is M mode. Suppose this, I measure this again for you. So look at this line, green line, which is going all across. So this will tell
Yes,
you
sir.
where is the maximum systole and maximum diastole. Okay.
Okay, sir. Thank you, sir.
Dr. Mahananda Matre.
So two questions. Color flow propagation velocity, then hepatic vein Doppler study and pulmonary venous Doppler pattern. We have to see grade 3 and grade 4 diastolic dysfunction patients, because hepatic vein sample volume I had seen very few
Hepatic vein
patients.
sample volume is not related to diastology. Hepatic vein
Okay.
sample volume is related to right side.
Okay.
Then pulmonic vein Doppler spectrum pattern could be related to diastology. In some cases, when you're looking for reduced ejection fraction, if you happen to see three parameters which I showed you, 0.8 to 2, in those three parameters, one is positive, one is negative, and third is ambiguous. So what do? I go to pulmonic venous Doppler pattern. Normal S wave, systolic wave is bigger than D wave.
Okay.
If systolic wave becomes smaller than D wave, then I'm possibly looking for grade 2 diastolic dysfunction.
Okay, sir.
That's 2. And third was color flow propagation velocity. Color flow propagation velocity is a very useful parameter in atrial fibrillations.
Okay.
What we do in atrial fibrillation, we look at E to E prime septal ratio more than 11, IVRT less than 65 milliseconds, and EVP ratio, color flow propagation velocity, E wave divided by color flow propagation velocity more than 1.4 is suggestive of restrictive filling patterns. As such, color flow propagation velocity is important. Normally, the slope is less than 55, more than 55 centimeter per second, and in restrictive filling pattern is less than 35 centimeters per second.
So can you show once how to measure it again?
Okay. What do you want to see?
Color flow propagation velocity.
Color flow propagation velocity. So I have to look for atrial fibrillation patient. Okay. You can see my screen, right?
Yes, sir.
Okay. This is a patient of atrial fibrillation. Can you pick at atrial fibrillation in this patient?
Yes.
By ECG gating? These are fibrillatory wave in between. Can you see these fibrillatory waves?
Okay.
So this is color flow propagation along with this M mode. What do? We switch on color, put an M mode across this. So we measure the flow across LA to LV in colors.
Okay.
And then we look at this Doppler spectrum pattern. I'm going to increase the sweep speed. Give me a second. Horizontal sweep. Yeah, I'm able to do it. So what I'm looking at the sweep speed is, I've increased the sweep speed in the sense how many frames are there in sec. Normally we keep 50 millimeters per second. So I can go to 66 or 100 millimeter per second to look at the clear Doppler spectrum pattern. Among all these things, this is not clear, this is not clear, this is not clear, this is not clear, this is not clear. This is the only one which appears to be very clear. So I'm going to measure my slope pattern in this patient. Go to slope caliper, look at the beginning of QRS complex, go 4 centimeter up. Now look at the screen on left hand side, the length. This is 5, 4. Now 4 centimeter up I'll go.
Okay.
And once I go to 4 centimeter up, I'm going to align my flow pattern as far as, now look at this, yellow and blue. The first aliasing velocity where I'm utilizing, I've gone to 4 centimeter up.
Okay.
And this is what is known as 29 centimeter, which is significantly reduced.
Okay.
And we have to choose pattern because we have to wait till we get a clear pattern. This is only A wave. We don't see E wave. We do not see A wave at all over here. Normally we'll see A wave also. So this is
So
how
that,
we look at black and white interface. Like first aliasing velocity from yellow. This red and yellow are the part of each other. And blue and yellow, you go along with the line to measure your slope, which is almost 29 centimeter per second. So
slope
if E wave
caliper
is,
that.
just a minute.
Huh.
If the E wave is 100 divided by 29, that will be almost 2.5. The ratio has to be more than 1.4.
I'll read again still. And sir, that slope caliper format is there, or only that caliper knob only we have to use?
In measure, we have a slope caliper.
Okay.
This machine will tell you slope caliper. As soon as it will show you a color flow propagation velocity, look at the machine. If it's a G, I don't know much about Phillips.
Okay.
Go to mitral valve will show you slope caliper.
Okay. I'll see, sir.
And if
Tomorrow.
it's not there, ask the vendor. They'll open it up. Whether G,
Okay,
Phillips, whatever it is.
And sir, one more question. In hypertrophic obstructive cardiomyopathy patients, hereditary, like if there, I have got two patients. One was not having outflow tract obstruction. So whether their children's, while asking for screening, it is all males and females both should be screened, or
Ideally, the complete family should be screened.
Autosomal dominant.
family,
Autosomal dominant.
dominant, so whole family. And one patient who is not having outflow tract obstruction, he should be screened yearly, whether he can develop that later or.
Because you never know about these people. We have to screen, because once you find a hypertrophic obstructive cardiomyopathy, what I do is always call all family members to look at for this.
Okay.
And if you don't find an hypertrophic obstructive cardiomyopathy, what you are bothered, you are looking at the variant of hypertrophic cardiomyopathy, because the variants are many. Like you can have only apical hypertrophy, you can have only septal hypertrophy, you can have only lateral hypertrophy, you can have mid cavity gradients, you can have obstructive hypertrophic cardiomyopathy. So variable variety of hypertrophy could be possible.
And one more, sir, about the non-compaction of LV.
Okay.
Sir, please once more explain this, sir, please. What was color flow population?
Janvi, you said when I was about to close, you said 10 seconds before.
Oh.
Okay, I'll go back. Janvi, what I'll do is I'll show you in a much better format, right? Give me a second.
Okay.
Can you see this slide now?
Yes, sir.
Okay, thanks to Janvi, we got a better slide.
Thank you.
This slide category shows presence of E wave and A wave, and this is diastasis in between. Correct. Look at this correlate with ECG gating. So here is a T wave end, and this is a beginning of E wave, then diastasis, then A wave, and then beginning of QRS complex. And this patient has got an MR also. Now what we do is, this is opening of mitral valve. Look at this mitral valve opening. So we go from this red, blue, and we go along with this blue line, start with the mitral valve opening and go almost 4 centimeters up, and then align our line along with this yellow and blue interface. Now look at the sweep speed is 50 millimeters per second. Make it 100, it'll be more clear. Like it'll spread out. Okay? When it spreads out, you'll be able to see a very clear difference between red, yellow, and blue, and go along with the red and blue lines. Then you go 4 centimeters up, take this line, align with this color, then you get a slope caliper. 55 normal, less than 35, restrictive volume. It used to be there for a long time, but gradually given up with 2016 guidelines.
Okay. Yes. Thank you, sir.
Thank you. So let's next take Dr. Mahananda is over. You want to ask something more, Dr. Mahananda?
No, sir. Asked.
All right. Dr. Lalit Bhardwaj.
Good evening, sir.
Good evening, Dr. Lalit.
Sir, except from PISA, do we need to adjust Nyquist limit in any other condition, or
Correct.
I'm not getting this Nyquist thing, sir?
Hepatic venous flow pattern, pulmonic venous flow patterns, coronary blood flow.
Okay, how much to adjust those things, sir?
In PISA, we bring it down in MR, we take it up in AR. Like in MR, we bring it down to 20 to 30 centimeters, correct?
Yes.
In hepatic venous flow, pulmonic venous flow, coronary artery blood flow, we reduce the scale, not on one side. We reduce the scale up and down, both sides, by bringing it to 20 to 30 centimeters.
Okay,
For better flow pattern. Because normal hepatic venous flow pattern, pulmonic venous flow pattern, and coronary artery blood pattern is almost 30 to 40 centimeters per second. So we bring down to this Nyquist limit to 30 to 40 on both sides in these 3 conditions, and PISA for AR and MR in the direction of a jet, we bring down to 20 to 30 centimeters.
Okay, sir. Sir, next question, how to differentiate ischemic DCM versus idiopathic DCM, sir?
Not idiopathic, we can say dilated cardiomyopathy versus ischemic cardiomyopathy. Correct. Okay, let's go down. I don't like, because I had loaded these cases today, because let's just me try to show you if I have loaded it completely today. Yeah. So this is a patient whom we say possibly a dilated cardiomyopathy or ischemic cardiomyopathy. Let's look at the images first. We cannot make much of a diagnosis here. This is average what we get in our lab, or you must be getting the same thing. So this guy has presented with congestive heart failure, and we went on to do a TDI for this patient. Now look at the medial TDI, 6.6 S wave. Then lateral TDI, 11.1. Then inferior TDI, 6.8. Lateral TDI, anterior TDI is about 10 or 12.3. Then we went into RV free wall, 13. and RV free, sorry, posterior was 13 and RV free wall is 12. Anything more than 7 is considered as normal. Now look at this. Septum is reduced, medial is reduced, lateral is normal, inferior is reduced, anterior is normal, and so is the posterior. So out of 5 velocity, 2 of them, septum and inferior, are reduced, rest all are normal. Now concentrate on this imaging quality. I will change the colors for you. Let me just try to change the colors for better visualization. So what is abnormal in this patient? Let me increase the gains. I think there'll be a better answer. Look very carefully. Lateral wall is contracting, septum apical is contracting, mid and basal septum is not thickening. It shows a jerky motion, but it's not thickening. There's no endocardial thickening. Look, there's endocardial thickening out here. And if you go to two-chamber view, the same thing is happening. Whole of the anterior wall is contracting, apical anterior, apical inferior is contracting, and this shows hypokinetic motions. So one of the way to differentiate between ischemic versus dilated cardiomyopathy is to look for tissue Doppler imaging velocities. Second is clinical evaluation. Like you optimize these people because the treatment will remain the same. You optimize these people, you start finding a wall thickening abnormalities. If there is no wall thickening abnormalities, possibly you are dealing with DCM. If you find a wall thickening abnormality, as in this patient, this is ischemic cardiomyopathy. Is a very good answer is if you have a dilated cardiomyopathy, normal coronaries, a true DCM will always involve right ventricle. And ischemic cardiomyopathy, right ventricle may be involved or may not be. Third is we start looking at the strain pattern of these people. So this is what we do a strain imaging in this subset of populations. And if I concentrate on this strain imaging, if I look at this zoom view of this strain imaging, look, anything more than 17.7 is considered as normal.
Normal.
In this patient, look, inferior, posterior, posterolateral wall is fine. Inferior and septal, look, they're significantly reduced on this side. It's not only that, even apical segments are significantly reduced. If I have to believe on this strain imaging, I'm very sure septum and inferior wall, they are involved, and maybe to some extent, the apical LAD territory is also involved. Posterior, lateral, anterior, they're all spared very clearly. Posterior is a lateral to a large extent. Mid and basal, posterior is normal. Mid and basal, lateral is almost normal. 17 is the cutoff. This is 16. Rest anterior, basal anterior is normal. It means we are dealing with somewhere mid LAD lesion along with RC. And this is not diagnostic, it is suggestive. In case it's a dilated cardiomyopathy, every segment would be uniformly, almost uniformly reduced. That's how we look for strain pattern to differentiate between ischemic versus dilated cardiomyopathy. But at the same time, I'd like to tell you one important thing is, these are correlative measurements. They don't tell you 100%. So final answer, if I'm a treating physician, whether it's a dilated or ischemic cardiomyopathy, I always say that these people should undergo angiogram.
Coronary angiogram. Yes. Yes.
Because coronary angiogram is easily available today. And in the hand of safe people, we hardly need about 20 ml of a dye. And it's a walk-in, walk-out process today. You do with a radial artery. And maximum time, how much take to do a radial artery coronary angiogram is hardly 8 to 10 minutes, max to max. And once we do a coronary angiogram, we can discharge the patient then and there in next 2 hours from there. And cost is 10 to 12,000 rupees. But if it's abnormal coronaries where you find abnormality, then the problem comes. Whether this needs to be dealt with, we do need to deal. We do FFR during the time, or else we subject the patient to low-dose dobutamine echo to assess viabilities. Although in corporate and hospital, nobody does that today. If you happen to see a closer or some stenotic levels, we always take up form matter that we are going to open it. So what I do, like I always look at these people presenting with DCM. If stabilize them, once after stabilization, if they start separating out in ischemic, we do a low dose dobutamine to assess viability, and then we take them up for coronary angiogram. So we are ready if the vessel is to need to be opened up or need not to be opened. Many of our colleagues, my colleague will not agree with me what I'm saying. Because once they say that if you have a patient with a dilated cardiomyopathy, take them, stabilize fast, take them for angiogram, do an angiogram. If the artery is blocked, open it up. Forget about everything in the world. So both the views are available. Depends on you what kind of view you want to follow.
Thank you, sir. Very nice.
All right. Anybody else? Long time? Like I could understand very few people are really interested in asking questions. They're about 40. We started with 67. We have 68. We dropped down to almost 44.
One request I have to do, but that I will do that one.
Okay.
Actually, we have postponed our instead of October, we are going to join in January. But here is 2-in-1, sir. But I can pay for that hands-on separately for me. Is it? Are you going to allow me, sir?
What is your qualification?
I am MD medicine.
Oh, both of husband and wife want to come together.
Yes, sir. It is only for 4 days, so I can also come. But I will pay separate fees for me, and if you allow me.
So you already joined one complimentary, one with each other.
Presently, that is
that
going
right?
on. But for hands-on, you charge me, sir. I will pay, and if you are allowing, then I can.
I have never said no to anybody. Believe my words, Janvi. I never ever said anybody no.
To ask Dr. I will ask Reena ji to ask for payment, and then in January, if you allow, we will both come simultaneously.
Sure, why not?
But
You can.
okay, sir. Okay, sir.
The day
Thank
you will do a good job in your place of work, believe my words, that's my remunerations.
Yes. Okay.
One of my students is practicing in Noida. You know, somebody called me up, Dr. Gupta, there's a one report which I want to send you. And that report is excellent, you know.
Okay.
And that guy, very devoted person, he's a migrant from Kashmir, but he does basic, he did his advances, he did his fellowship in echocardiography.
Okay.
And whatever we taught Janvi to him, he's putting all those things in everyday practice. He does not do 100 echoes. He does not do 20 echoes. He does only 5 to 6 echoes a day.
Yes.
An excellent way, the way he's reporting those things. And when somebody told me, look, this is what he's doing, I believe our word, we were the most happy people. Look, somebody has adopted our practice.
Yes.
And that's what we call them. I want to call those people who are doing good. Let them come and work with us as a faculty. When you come to us as a faculty, we take care of everything, tickets, stay, remunerations, whatever the practice you have lost.
But first, I have to prove myself, sir.
You have to prove yourself.
If
Many
I
of the
prove,
students now, they're coming as a faculty now,
yeah,
hands-on session. We have a faculty of almost 15 to 20 people. The people ask, sir, when can we come?
yeah, yes,
And it's like family. We enjoy each other. We'll go to the dinner. We enjoy food. And everybody is so comfortable in asking any questions related to echocardiography, related to practice, related to legal matters.
yes. Okay, sir.
Sir,
Thank you.
one last question, sir. So when you talk about the coronary angiogram, sir, usually you prefer, sir, conventional angiogram or CT angiogram. When do you ask for CT angiogram, sir?
$1 million question. How much a CT coronary angiogram cost? How much is a conventional angiogram cost? In Delhi, CT angiogram is approximately 15 to 20,000 rupees. Conventional angiogram is 12,000 rupees. In CT angiogram, if it's a negative, the negative predictive value is 100%. If it's positive, the positive predictive value is much less.
Okay, sir.
Correct?
Okay,
If I'm suspecting coronary artery disease, why should I subject my patient to CT coronary? Now the question, when do I order for coronary CT?
yes,
I
sir.
order a coronary CT when I'm not sure whether I'm dealing, my stress echo is normal. I have a slightest doubt, possibly this is positive. Then I'll go for CT coronary angiogram. High risk profile like pilots,
Okay.
post PTCA, CT coronary angiograms. But even in sitting in Delhi, there are very few centers who does a good CT coronary angiograms. Why is that? Because
radiologists are not cardiologists.
not that way. Forget about that. What is exactly CT coronary angiogram money?
Sir, we inject the dye through IV.
Okay.
And study the vessel, coronary vessels.
How do we study coronary vessels?
I don't know, sir.
Okay. We take a cut section of a coronary arteries and the computer joins them up to make a structure.
Okay.
My heart is not a static structure. My heart is a dynamic structure.
Okay.
So my heart beats at 60 beats per minute. Correct? So every 1 second, it will do a complete cycle. So first of all, I should have a machine which takes care of my heart in the sense that it should be scan my heart in less than 1 second.
Okay.
One. Then what you need is slices. A minimum 256 or 512 slices per second. You know what is the cycles? Like the gantry comes from both the sides, gantry comes from both the sides and cut the heart to multiple slices. If I take 250 slices per second, it means one beat has been divided into 250 slices. Then my accuracy of CT coronary angiogram is much higher as compared to the accuracy of 6 slices per second. And majority of places, they are 6, 12, 24, 48, 96, 112. That's one reason. Second important issue is if some plaque is present, then we have to identify the quality of plaque. Whether the plaque is fibrous, fibrofatty, or fatty. If it's a fibrous plaque with a 70 to 80% of stenosis, I'm not going to do anything. If the plaque is fatty, even if the stenosis is 30%, I have to do an angioplasty for the patient. And third important issue, what Dr. Janvi said is, like majority of people who are doing this CT coronary angiogram, they're not cardiologists, they're radiologists. And my experience is pretty bad in my area. Whenever I send somebody for a CT coronary angiogram, I don't get an adequate response. Maybe I have got unfortunate too much of a knowledge, or maybe they are much wiser than me. Because whatever they write, if I believe on that, I don't subject them for angiogram. And if once I don't subject them for angiogram, they come back in a few days or few weeks or few months time with abnormal ECG and reduced LV systolic functions. So I always prefer, if I have to do a coronary angiogram, I'll go for a conventional coronary angiogram, which costs me about 12,000 rupees, and just walk in, walk out process.
Okay, sir.
And dye uses in CT coronary 100 ml. Here the dye uses about 20 to 30 ml.
Okay, it's very less.
So, and maybe like sometime like we have a dye use hardly 10 to 15 ml. So that's what I prefer is, I may be wrong. This is my personal views. Many of the views will be variable.
Okay, sir.
Dr. Raviwala Mahajan, last question.
Thank you, sir.
Yes. Sir, what is non-compaction of LV?
Wait a minute. I'll show you non-compaction of LV. Because telling and showing you a picture will make a lot of difference.
Yes, sir.
Once you see a picture, you'll never forget in your life. If I'll tell you, you'll always forget in your life.
Yes.
Slide number 95. Okay, done. Okay. I'll try to get you another one. Look at this picture. If you happen to see multiple thrombi in LV, look at this picture over here. Let me just zoom it for you. Can you see this picture?
Yes, sir.
This is two-chamber view. Look at the bases which are spared. Apical septum shows multiple burrowed kind of a, as if like insects have burrowed into the endocardium.
Yes, sir.
Look, multiple of them. And if you happen to switch on colors in them, you'll find the color is getting into these burrowed endocardiums. I can't show you in this. And in like when we use three-dimensional structures, apical segment shows burrowed endocardium, basal segment shows normal endocardium. And yeah, look here the blood is, now this is much better. Look, this is basis.
Yes, sir.
This is spongy or non-compaction of it. The word is changing from word to words. We used to call spongy myocardium, then we said non-compaction of LV, and then now we say hypertuberculated LV.
Okay.
Look, this is apex, bases are spared. And this is what is short axis view. We look at a compacted versus non-compacted segment. Compacted means this is all compacted segment. But once you look at this segment, which is extending to this point, this is known as non-compacted segment.
Yes, sir.
Compacted versus non-compacted segment ratio has to be more than 2:1. So this is non-compaction. So this is non-compacted segment. This is compacted segment. Normally, we'll not see this non-compaction. We'll see only this segment in a state, normal state.
Yes, sir. Yes.
And majority of these people, they have abnormal filling patterns. They'll not have a normal filling patterns. They have abnormal filling patterns. So that's what is seen in this subset of population. And let me just show you one more important picture if I could locate it in 1 minute. If you see that picture, you'll never forget in your life what is non-compaction of L.
Is this because of multiple thrombus, sir?
No, there's no multiple. There's chances of developing a thrombus in this subset of populations. But we don't have a thrombus in that. This is like the segment. Look, endocardium, myocardium. Myocardium, endocardium does not get collected together. That's how it works.
It will be since childhood, sir.
Yeah, it will be by birth only.
Okay.
And majority of these people of true non-compaction, they do not go to the age of midlife because they'll present it with dilated heart. And when they'll present it with dilated heart, they have a restrictive filling patterns. What we see in day-to-day life is when the LV get dilated, it looks like non-compaction, which is not correct. So that's what the importance of compaction versus non-compaction. It's not an acquired disease. It's a congenital disease.
But it is only problem with endocardium, sir.
Endocardium. It's taking couple of minutes and let I could remember one patient who was a newborn and had non-compaction. I could remember him very well. Just give me a second. Otherwise, it's taking a very long time.
Endocardial cushion defect, sir.
No, non-compaction
No.
is not endocardial cushion. Endocardial cushion defect is something different. Yeah, it's here. It's going to create a trouble, but let me just try to show you what is non-compaction. Hopefully, I should be able to show you this slide because this is a very old format. The new computer does not accept it easily. So this is what in short axis, which I wanted to show you a non-compaction. I'll try to play it again. Look, this is what you can see multiple non-compacted segment.
Yes, sir.
So this is what a classical non-compaction is.
So it can be seen in any endocardium, RV, LA, LV.
Both. It could be in both endocardium. But true non-compaction is a congenital disease. It's not a acquired disease.
Yes, sir.
And this patient was a newborn. Look at the 6 months child, refer for echo. Persistent beeping all the times, failure to thrive. And this was a child echo. X-ray is not very good, but this is a child ECG. It's a quite old collection of cases. Now this is a look at the presentation of this child, LV, LA, RA, RV. So predominantly dilated LV, dilated LA. And majority of these kids, they do not live for longer duration. They have got a severe mitral regurgitation. And look at the apical segments. They are all non-compact. Look at the hypertuberculated apical segments.
Yes.
This is somewhere at the age of like, when did I record? I don't remember it. It's pretty old collection of cases because it's in a old formats. I can tell you when this was recorded, long back, almost 2004 or 2003. Is that okay now?
Yes, sir.
Comfortable?
Thank you, sir. Thank
So
you, sir.
next week, get ready for examination.
Yes, sir.
Yes.
We'll have exam on Friday. Friday. 8
Topic,
to
sir?
9,
Which
9:30.
topics are?
Same, systolic, diastolic, and cardiomyopathy.
So how
Okay.
many questions?
60 questions in 2 hours time. That'll be okay?
Yes, sir.
Thank you,
And
sir.
after that, we'll have a
Thank you, sir.
class on
Shubhratri. Thank you, sir.
right heart and pericardium.
Yes, sir. Thank you, sir.
Good night, sir.
At what
Good
time,
night,
sir?
sir.
Pardon? We'll have a class at 9:30 after the exams.
After exam. Okay, sir. Thank you, sir.
Good night.
Good
Bye-bye.
night.
Take care.
Good night.
Good night, sir.
Thank you, sir.